presenting the patient. My patient name is Soheli. She is 40 years old. She came to me outside the Dhaka city with the complaint of lump in her left breast, noticed for 3 months. And this lump was initially very small in size, but was progressing and becoming, and there was no pain. After 2 months, she noticed that there are multiple opening over the lump and presented with to me with multiple discharging sinus. And regarding her details, she is mother of one child who was 3 years old, but she died last year accidentally. So she found now she's pregnant again and amenorrheic for 3 months. So she considered this pregnancy as a valuable one, and so she didn't give concentration on this lump actually, and she is non-diabetic, non-hypertensive. There is no family history of carcinoma breast in her family. Had further died from carcinoma stomach, and on examination we found the lump is fixed, and there are discharging from the sinus fixed, but it is fixed with the skin, not with the underlying structure, that is not with the muscle. And on examination, the lymph node is not palpable, but on ultrasonogram findings, we found that there are some, the lump size is 3.2 to 2 into 2.1 centimeter, and there are two enlarged lymph node are seen. Mammography, on mammography, there is no densities. There is density, but no specific SOL, or it was by that 3 category. It was found by that 3 category, and whenever we go for core biopsy of the lump from the breast, it features that it is infiltrating breast carcinoma. And on the report, when we went for the receptor study, they again did the review study of the slide, and it was found that it is ductal carcinoma in situ with focal microinvasion. And triple receptor studies report was triple negative. So the scenario become a bit clumsy, and we are suggesting your opinion for her for the next steps.
Thank you, Dr. Sumi, for nicely presenting your interesting case. Now we'd like to have some opinion and discussion from our honorable faculties. First, I'd like to go to Professor Ben Park regarding this case. What could be the next treatment option? Ben Park, sir.
Yeah, I'm sorry, I may have missed it, but did you say there was enlarged lymph nodes at all?
Clinically, I didn't find any lymph nodes, but sonographically there is lymph node.
I don't know if you routinely do this, but sticking just a fine needle aspiration to verify that this patient has cancer there, because you know, with just having in situ disease and just microinvasion, probably we would not do an upfront neoadjuvant therapy approach. Now, if she has positive nodes, on the other hand, that would change. And then I would think about giving her neoadjuvant therapy upfront to try to see if we can shrink this and try to get pathologic complete response. It's a little unusual for triple negative breast cancers, as I'm sure many of you know, to have so much of an in situ component and only have microinvasive disease. Generally, for triple negative breast cancers, we see kind of the opposite, where we believe that the cancer cells are so aggressive, we don't really see much of an in situ component. So this triple negative may in fact be what we colloquially call as luminal androgen receptor positive triple negative disease, which behaves more like ER positive breast cancer, but is in fact androgen receptor positive, but ERPR negative. And again, in those cases, they're less sensitive to chemotherapy. So I would like to know what the nodal status is. They or radiographically seem enlarged, but it's not clear to me whether that's reactive or in fact if she truly has nodal disease. I think it makes a big difference in this case because if she's in fact negative nodal, that you might just consider doing an upfront surgery approach and then getting the complete staging versus if she's got positive nodes, proceeding with a neoadjuvant approach and then seeing what her residual tumor burden will be after neoadjuvant therapy. She's so young, it's hard not to give chemotherapy, but if she ends up just having microinvasive disease, I'm not sure there's going to be a huge role for that.
Anjana Joel, madam, would you like to add something to this case?
Yes. Hi, Amasha. So thank you. Thanks, Dr. Sumi. So I just have a couple of comments. Now, when I looked at that ultrasound report that you had shown, there were also significant 90 millimeter lymph nodes in the contralateral axilla as well.
Yep.
Now, that is worrying because if you have a significant lymph node, which is say almost 2 centimeter in size in the contralateral axilla, that is metastatic disease. So I would want ideally an FNAC of that as well, because if the contralateral axilla is positive and that also shows a triple negative breast cancer, we're dealing with something which is not only aggressive, but it is also widespread. Now, in terms of staging investigations for her, because clinically she does have what seems like locally advanced breast cancer, which is also pregnant. So ideally, this is somebody where we would do a CT thorax and a bone scan, but for her, because of the pregnancy, we would not be able to do that. At our center, we are prospectively evaluating the role of a whole body MRI in these sort of patients, wherein you can do that as a metastatic workup. Now, I'm not sure about the feasibility of a whole body MRI there. Yeah. If it is possible, I think it's something which is worth doing as part of your metastatic workup. And I totally agree with Dr. Park in terms of this whole the in situ component. I mean, that's something which is just not fitting in with the whole picture of a TNBC. And, either ways, looking at that clinical picture with nodal involvement, even as contralateral lymphadenopathy, if the contralateral axilla is positive, that's metastatic disease. Now, if you communicate that to her, I don't know if her decision on continuing her pregnancy will change or not, because that is a discussion in itself. Because here, I think her decision on continuing her pregnancy is hoping that she has a locally advanced breast cancer and we treat her with curative intent. So, I mean, to me, that contralateral lymph node FNAC is important because, it will help you prognosticate, stage her better. And also maybe the decision making on the pregnancy might be slightly easy. I'm just thinking out loud here. Okay. Does that make sense?
Yes.
Thank you. May I ask my queries? And that is that yes, she has lymph node on the ultrasonographic findings. We get it. It may be reactive. It may be malignant, definitely. But whenever if we go for the neoadjuvant therapy, and that is chemotherapy, then what would be the differences? Should we do it for the purpose of staging and prognosis, or any other things? Any other modality will be changed according to the decision of the FNAC finding?
Yeah, I think it will help you because even if that node is the only site of metastasis, and you do give her chemotherapy with a neoadjuvant intent, and if she really does respond well, you can always do your left MRM and do a right axillary node sampling or dissection or whatever, as part of your curative intent therapy. So in that sort of a setting, it would really make sense for you to have FNAC that at baseline before you start your neoadjuvant treatment. So I know the treatment is not going to be different. You're going to give her chemotherapy, but still, it would make sense for you to know that, one, for prognostication, and even if you do treat her with neoadjuvant, saying she's maybe oligometastatic if the axilla is the only site of disease, and then you can always address that axilla as well, because you don't sample it. You're not going to be, you're at the end of your neoadjuvant, you're always going to come back to the same question of do I need to address the contralateral axilla or not. Okay.
I was going to add to that there could be, she's such a young woman. having some sort of genetic germline testing for BRCA1 or 2 would be appropriate. But that's also a situation where she could also have bilateral primary. So one has to consider that even if she has positive disease on the contralateral side, could she actually still have maybe occult malignancy on the contralateral side, and that you're dealing with bilateral breast cancers? I think that would be another reason why sticking a needle in there. If you get cancer cells, you could also do receptor staining. And if they're discordant, then you probably are leaning towards the fact that they're probably different primaries, as opposed to if they're concordant. It's still a little inconclusive, but I agree with Dr. Joel. It might be something to consider, that this is metastatic, and doing staging, if possible, with the fetus would be desirable. I also think if you are going to give chemotherapy during pregnancy, really, we usually just use the AC component first. And that's been shown that you can do it after the first trimester. But sometimes then we will reevaluate and do the delivery if we possibly can, and then give the taxane component afterwards if we're going to do AC&T. There's not a lot of great data for contraindications in pregnancy, but most of us feel AC is safe, again, after the first trimester, where taxanes probably are not.
Thank you, sir. We move on to Professor Rajesh Balakrishnan, sir. Rajesh, sir.
Thank you, Arnangshu. I totally agree with what Dr. Ben Park and Dr. Anjana said, but I would also want to make a comment that in the Indian subcontinent, with any woman with a breast having discharging sinuses and axillary nodes, we should rule out tuberculosis. So most common cause of discharging sinus in the breast with bilateral axillary nodes, I think we should definitely try to rule out tuberculosis. Maybe we might need to screen for other lymph nodes in the neck. Maybe an ultrasound neck would also be a good idea to start with. And maybe the sinus, whatever fluid is discharging, maybe we can send for a AFB smear of it also.
Okay.
Then, sir, what do you? Is it common to get the tuberculosis and the malignancy in same patients? I want to know about your experience, and at the same time, I want to know then what do you suggest for confirming the tuberculosis in such patient? What can we do?
Maybe I think we should refer to an infectious disease specialist for that. We can get both malignancy and tuberculosis in the same patient. We have had a few occurrences where the breast had a malignancy and the lymph nodes were tuberculosis. Sometimes we treat them with ATT depending upon the ID specialist opinion. Sometimes we don't. So it's a decision which the ID specialist has to make.
Okay, sir. Qamruzzaman Chowdhury, sir.
We got the idea from the Professor Ben Park and also the Rajesh, and also actually thing is that this patient has a right axillary lymph nodes. Lesion is in the left. Actually, there's a big lesions, 3 into 2 centimeters, and also with a left axillary lymphadenopathy. That's also bigger one. But right axilla, there is also one lymph node. So I think, can we go for one FNAC from the right axillary, whether the patient has been the bilateral involvements or not in that cases. And we can go for other things like what the Ben Park has told, whether if it is a TNBC, we can go for the BRCA1 and 2s in these cases. This is a very, and in Bangladesh, usually the cases are coming in very advanced cases. So in that case, we'll have to think for the neoadjuvants and other things. That's all.
Thank you, sir. Salim Reza, sir.
Thanks, Dr. Arnangshu. I am fully agreed with the previous speaker's comment. In this locally advanced disease, what Qamruzzaman has mentioned here, she should need the axillary biopsy on the right side for what is the pathology in this right side axillary lymph nodes. Then in these stages, definitely treatment protocol will be the neoadjuvant chemotherapy. If it is the 3 months pregnancy, in that we know that in the second trimester, the chemotherapy is feasible, especially the doxorubicin chemotherapy. So I'm in favor in the neoadjuvant chemotherapy with the doxorubicin chemotherapy.
Is there any discussion left on this case, or we'll move on to our next
I have
case?
one query. If you, what stage
Sure,
will
sir.
put this patient as T stage? T4 or?
That's an interesting question, sir.
Shumi, I think the lesion is a 3 into 2 centimeters. Is a T2, no?
Yeah, but when sinus is there, whether that changes.
But there is a discharging sinus, so we can
Yes, sir.
consider the skin infiltration may be there. So,
But if it is associated with the tuberculosis and others,
yeah, that need to be excluded.
I think the other difficult part is that it, again, from what I recall, the pathology is microinvasive. So the entire mass is mostly in situ disease.